Hello, everyone. My name is Calvin Ryan, and my pronouns are he, him. I am the research assistant for Dr. Antoinette Farmer, Associate Dean for Diversity, Equity, and Inclusion at Rutgers School of Social Work. I will be graduating with my MSW degree in 19 days.
Hmm.
Uh, the IDEA Committee, which stands for Inclusion, Intersectionality, Diversity, Equity, and Advancement, was established in fall 2020 as a part of the school's strategic plan toward a more just future. The IDEA Committee advances diversity, equity, and inclusion initiatives within the School of Social Work, the university as a whole, and the larger social work community. Thank you for joining us for another Research Spotlight interview. I am here today with Dr. Lister. Jamey Lister, PhD, MSW, is an associate professor with tenure at Rutgers School of Social Work. Dr. Lister currently serves as the New Jersey director and region-wide co-director for the Northeast and Caribbean Rural Opioid Technical Assistance Center. The center serves rural stakeholders in HHS Region 2, which includes New Jersey, New York, Puerto Rico, and the United States Virgin Islands, and is part of a national network of centers funded by SAMHSA. Dr. Lister's community engaged addictions research targets solutions for rural and underserved populations by placing an emphasis on practice and policy recommendations, identifying strategies to reduce barriers to care, and utilizing research methods that promote health equity. Having grown up in a rural and medically underserved area of Michigan guides his scholarship and intention to promote trust with community partners. Prior to joining Rutgers, Dr. Lister was on the faculty and completed a postdoctoral fellowship at Wayne State University, an urban serving university in Detroit. Some of his diversity, equity, and inclusion focused research has been published in the American Journal of Drug and Alcohol Abuse, the Journal of Rural Health, Rural and Remote Health, and the Journal of Healthcare for the Poor and Underserved. Dr. Lister earned his PhD from Rutgers University, his MSW from the University of Michigan, and his BS from Miami of Ohio University, each of which was in a social work educational program. Hi, Dr. Lister. Thank you so much for agreeing to speak with me today.
Hi, Kelvin. Nice to speak with you, and thanks for the invite from you and Dr. Farmer and the IDEA committee to join. It's a cool initiative that you all have going. Watch some of the others, and I'm excited to talk some about my research and intention for DEI efforts today.
Yeah, of course. Thank you. So for our first question, can you please tell us about a current research initiative of yours that is related to diversity, equity, and inclusion?
Yeah. I mean, I think the one I wanted to focus on today, because I'd say generally my research projects look at DEI in a few different ways. One is the place of where somebody has grown up or where they reside. Another is race ethnic status, which might lead to disparities or social marginalization. And then the third is kind of economic disadvantage that a person or a community may face. So they kind of collectively, my projects try to look at one or more of those domains in ways in which research can help promote more equitable opportunities for people that face those types of social disadvantage. The one that I'm kind of spending a lot of time on today that I think gives a unique DEI kind of lens is that position you referenced in the bio blurb about the Northeast and Caribbean Rural Opioid Technical Assistance Center. So you mentioned that it's part of a national network of regional centers that essentially cover all rural communities of every state and territory in the United States. So our role is in the states and territories in HHS Region 2. But me particularly, my task or charge is to lead the rural efforts in the state of New Jersey. I work with the director at Columbia University kind of across the region, but then in New Jersey kind of have to push those efforts out, and we do that through Rutgers School of Social Work. The reason that it's a training and technical assistance center, so the goal of it is to try to provide free educational resources to any type of stakeholder that, is trying to improve matters for rural communities dealing with substance use and other behavioral health issues. And you might kind of ask yourself, like, why a focus on rural, right? Why not any place or an urban focus? So these types of training and technical assistance centers have been around for a long time, and there's a number of other ones that don't, overtly focus on place. They focus on addiction treatment or mental health treatment or prevention. And what's happened historically is that those projects were led by folks at large research one universities typically, and those research one universities almost invariably are located in urban centers. You think of Rutgers, where's our footprint mainly? It's in, New Brunswick, Camden, and Newark, all of which are urban centers. So when you have all these free resources and you're trying to engage with community partners, government stakeholders, healthcare organizations, coalitions, there's a ton of need everywhere. The opioid crisis and kind of the addiction crisis has not left any community untouched. And so what happens is if you're in Newark, New Brunswick, or say you're at another large university in a different state leading a different region, there's a ton of unmet need just in the urban communities surrounding you. So what tends to happen is the resources go in those communities because there's a need and it's more feasible for the researchers or the academics to partner there. And or if they are developing new partnerships, some of it's just the distance, right? You're like, hey, I want to meet this new coalition and they're 10 miles away versus 100 miles away. And so what has happened historically is that rural communities haven't really gained a ton of access to these resources. So the federal government put out a call saying in this next one, it's intentional that you need to focus on rural communities. And in New Jersey, just as some kind of overview for folks, our rural communities, we kind of fall into a gray area. By federal standards, we don't have any rural counties, but we have a few rural communities. But the state Office of Rural Health, which is in New Jersey Department of Health, uses a different definition. And by that definition, 7 of our 21 counties are characterized as rural. 4 of those are in the south. That's Salem, Atlantic, Cumberland and Cape May, Hunterdon in central, and Warren and Sussex in the north. So really our goal was to try to connect these resources largely to those 7 counties, but sometimes you have folks doing work in a county that's not rural, but they might have patients traveling in for care that are rural. So you might be in Morris County, but you're connecting with folks in Warren or Sussex. So really about half the state we've had an ability to try to connect with. And then connect with state leaders. And part of the reason that this work is so important is that rural communities face what's often called kind of the rural mortality penalty, where their health outcomes, their morbidity and mortality outcomes are quite poor relative to folks in urban and suburban areas. And this is kind of a facet that's not always well understood among academic researchers or social workers. I think in part because folks who grow up rural are unlikely or disproportionately underrepresented in higher education. So, because of that, there's not a lot of lived experience from people saying, hey, I grew up in a community like this and I want to, go into research or go into clinical work or policy work, and I have an understanding of what rural life is like. Then beyond that, you think of the same thing. If we're doing our practicum placements at Rutgers, like, is it easier to do a placement in one of the community agencies that's we already know, or to go build that with a community agency that's far away? Do you do it with an FQHC in Cumberland County? It's probably easier to do it with an FQHC in one of the areas that are right by FQHC, I mean a federally qualified health center. And the other thing that's, I think, a misperception among folks in our discipline is this idea that rural is kind of a monolith, and that most folks in rural areas are white, of non-Hispanic ethnicity. And so if we are committed to DEI with an emphasis on race and anti-racism, that how does it really fit? And I think one thing about Jersey is that we're really unique, that those counties I mentioned, especially some of them in the South, have racial and ethnic diversity that's inconsistent with that idea, right? That we have a high percentage of folks of Black or African American identity, or Hispanic or Latina ethnicity in those communities. So Jersey's rural health kind of landscape isn't the same as, say, upstate New York, or where I'm from, northern Michigan. And so here we have this unique opportunity to connect with folks that are facing some place-based disadvantages, but also experiencing race-based disadvantages, right? So there's this intersection of social disadvantage hitting folks in our state. But I grew up in a town of about, well, by some standards, it's 1,000 people. By another standard, it's 3,000 people. But in any event, we are federally defined as a rural community, as well as federally defined as a medically underserved community. What that means when you're medically underserved means that the health burden in the community is higher than the healthcare supply in the community. So here's how many problems this community might have with depression, with access to dental care, a need for primary care, and here's how many providers there are. And so, for me growing up, what I witnessed was we had inconsistent access to a primary care doctor in the community. At times one would be there, then it would go out of business. There's definitively no mental health or substance use providers, what we would call behavioral health in the community, aside from informal services. Can you go to the church and connect with like a self-help group that's talking broadly about a range of things people are working on, whether it's recovery from addiction, mental health, other eating, like any kind of health focus that is there, but those aren't necessarily the interventions that have the strongest scientific support for helping people achieve kind of long-term recovery. They're helpful tools. And so as a result, what I saw was a lot of people who died from fatal overdoses and suicides. And then this like growing mistrust in the community of whether or not healthcare providers or the state government really care, or academic researchers like myself care about the outcomes of people in their community, right? That they're not really ever included in these discussions. If they were, then you wouldn't be divesting all of the infrastructure of healthcare facilities. And what's happened historically in the last generation or so is a lot of rural hospitals have been shuttered. A lot of primary care facilities have moved to more urban, suburban locations. And part of this is the healthcare system is saying we have to design an approach that's feasible for us. And there's not many people in these areas. But what's happened is folks in communities like mine are saying, look, the healthcare system is really poorly suited for what I need. It's infeasible for me to actually access specialty care. Like where I'm from, if somebody needs a specialty care, let's say it's even for cancer screenings, dermatologic screenings, like that's not there. So any kind of thing you want that requires somebody with a more specialized healthcare training, even an MSW, they don't exist there. So you got to drive 30 minutes, 45 minutes, an hour to do those things. And if there's any routine care that's needed, like you got to come back, the research is really clear that when folks live that far away, the likelihood of staying in care, following up is dismal. And so that's kind of showed me that the healthcare system needs a lot of change, but also it's important for academics and leaders to come back to rural communities and say, like, what's wrong? What do you think needs to be changed? And there's anger, there's mistrust when you do that. But in the long run, the only real way to kind of bring those voices back to the table so that, approaches can be culturally centered it takes time. There's no quick fix. Like telehealth isn't going to be a quick fix. And we watched this in the COVID pandemic, that rural communities were much less apt to trust vaccines, social distancing strategies. But who were those messages coming from? They were largely coming from urban or suburban located folks who were saying these are the scientifically supported approaches. And folks in rural communities were kind of saying, like, I don't know you, you don't know me. Um, those messages you just sent, if anything, I might dig in my heels and say, like, I don't believe it because you told me, right? But if there's a true partnership, then and there's champions within those local communities trying to figure out how do we convey these health messages to people here in a way that they're apt to be responsive to. But that takes a lot more time, and I think oftentimes we don't take the time to do it.
Um,
Um,
just I guess as a side tangent, I in my social work practice two class, I was tasked with like going to an event in the community, and I live in a rural area myself. I'm from Maryland. I live in Queen Anne's County. Um, and that's a rural area, and one of the things I went to, like, a council meeting, and one of the things that they were talking about was, like, the lack of access of medical care, like, there's not a hospital, like a full running hospital in my county, and I think that's such a interesting thing that we don't talk a lot about in, you know, social work practice and education, and so I really appreciate, that perspective, and that definitely leads into to my next question, as you mentioned, which is, what are the policy and or clinical implications of your research for the field of social work?
yeah, and I appreciate you sharing that, Kelvin. I don't know that exact county, but we've traveled some to parts of Maryland and kind of on the West Virginia border, where, yes, totally, like you're saying, these same rural patterns show up. I do want to. There's one point that I realize I want to hit that to this idea that rural, because I think sometimes the history of DEI and social work is there's been so much unmet need in urban areas that there does feel to me at times like folks think of it as a zero-sum game. Like, we only have so many resources. There's so much need in the communities around us, and or maybe not a clear understanding of how dire circumstances are in rural areas. Every community is kind of saying we need more, we need better. But rural place. So the zip code you're born up in is highly predictive of your health outcomes in your life. And if that zip code is rural, especially a rural area that is economically disadvantaged, which is kind of the rule of thumb for most rural counties, usually those go hand in hand. Um, I think that people kind of sometimes in social work don't know that because they haven't seen it. But if you think about the intersection or the convergence of these DEI kind of foci, the areas where are some of the most pronounced health disparities in the country. They are rural areas with a high percentage of folks identifying as folks of color, right? So you think of the Deep South, those states have a large amount of rural landmass. So all of the built environment, built healthcare system stuff we just talked about is there. And then folks are also facing all of the things we know about in our DEI initiatives about how racism and systemic forces impact people's opportunities for, a life of quality, a life of equity. And I think that's kind of one of the ways I try to sometimes bring folks back when this question gets asked. Like, why do we have time to commit to rural with all the other issues that are at the fore? And, for me, I always just go to, we want to be where people need us in high demand. And I think it's going to take time. But I think what I notice is that my hunch is if we were talking about rural and we were at the University of Alabama, Birmingham, people maybe would get this convergence more because they're familiar with it. They know that rural place and race are they're not separate factors. Often they can be interrelated and make disparities worse. And rural composition is changing. The percentage of people who are people of color living in rural areas is increasing. So that's all stuff I kind of forgot about, but I know it is not this question. So I think the main thing, so I'll start with social work education. As an example, so here we are, we're at the 12th ranked school in the country, and this is not a knock on our school, but do we have any courses that are overtly focused on rural health? Not to my knowledge. Is that uncommon? No, I think hardly any MSW program would have an MSW focus course on rural health. There's part of it is we have so many accreditation standards we need to meet. There's already so many things to do. But again, it gets at this idea that if no one's getting training in rural culture, rural needs, I mean, how in the heck would they be prepared to deliver care in a culturally appropriate way if they don't know? And or understand kind of the extent of the issue if they don't know, right? So, and this is a national thing. It's not like the national social work organizations are doing this and Rutgers is not. It's just a kind of a hidden issue in our discipline. And I think that's largely, to me, again, reflective of where are our universities at. Is a smaller kind of regional public university. I got contacted at one point by a kind of a research two sized regional university in a Midwestern state. They were starting a rural focused health program. That's, well, in part because the people living in that community were largely rural. There's a big social work rural conference, but most of the universities that come to that are universities that are more like the size, they're not as big as Rutgers, right? They're regional publics. Some of them are like East Tennessee State, Ball State, Murray State, places that are committed to that work, but they're people they serve, the students and the agencies are more rural. So the issue is just kind of front and center. I think the main thing is at big schools like Rutgers, which can have a large impact, is being more intentional about where to fit this topic. How do we actually bring this topic into our curriculum in a way that is feasible? Because it's hard to add new stuff. I think more and more researchers in social work are starting to, I think, focus on, social workers have often focused on place-based disadvantage. So you're seeing more and more rural-urban comparisons, the intersection of place and race, all of those factors. There's a lot of health services researchers interested in that space. What we don't have in our social work research or even research across disciplines is data from people living in rural areas. What we have a lot of is big data, national data sets where we find out that folks in this region of the country or in rural versus urban experience disparities. Usually the research stops at that point. So there's a finding in the paper that says if you lived in a rural area, you were less likely to get this specialty treatment. And then that's it. It's over. What we really don't have is like surveys, qualitative interviews, community advisory board data where we're talking to rural leaders to say, like, what do you need? Or getting, questionnaires to find out what they say are the most pressing issues. So there's a gigantic gap in that space right now. I think in terms of policy and practice changes, so more applied stuff, we really have to take principles of community-based participatory research where our main guidepost is partnering on an equal footing so that it's not the big ivory tower academic coming in with all the knowledge, because that is a guaranteed way to get folks in underserved communities to not listen. It's just right away, you're coming in telling me you're the expert and you don't know anything about my community. People may not tell you with words, but they're usually tuning out. That building trust is the number one thing. That's the first pillar. Before you build any trust that this is an equal partnership, I care about your input. I want to include your input. It's not going to go anywhere. And even if sometimes what happens is we have short money, meaning like the federal or state government has come in or there's a research project, we're doing a study with this rural or underserved community. And then what happens is after the money runs out, partnership ends. So sustainability of those partnerships is key, that, we are committed to a long-term collaboration, and we're not just doing this until our money dries up and then we're going to leave you at that point. And I've had a number of times I've met with rural leaders where when I first come in, the question is about that. We've been burned before. We don't want to start working with you if this is going to be a 6-month thing and then you're going to, move on. I think some other things just in terms of policy stuff, there needs to be more policies that are centered around the goal is to improve access to care, for people living in underserved communities. So some of the regulations around you got to come in person to get your medication dose for opioid use disorder. I've advocated for exemptions to those policies if based on the place that you're from, to say, look, it's just not feasible for them, given how long it takes to get to the clinic. Some other options are kind of more uniform transportation subsidies or assistance programs for people that live a long ways from clinics, to say, look, if you make the effort, we'll provide mileage reimbursement. You can use, Uber Health to get to and from. And I think that those types of programs need to be minimize the amount of red tape that folks have to go through to use it. Because sometimes there are programs that exist, but they might represent kind of a challenge for somebody who maybe doesn't know how to act, like use all that information quickly. Because I saw your equity and inclusion backdrop was that I'm part of it's not a research project, but I'm part of the Office of Equity Inclusion's IIDEA program. They have their first cohort of fellows, and we're going through training now to kind of learn about how and where we want to lead, but reflecting on our own positionality, our own background first, our own personality, so that we can work with other people, whether we're leading, collaborating, or being led, in a way that's equitable and promotes kind of, I think, trust and collaboration. And I'd say that's maybe another thing that social work needs is I look at this program and go, this is really like a program about learning how to collaborate in an effective, trustworthy way that everyone would benefit from, whether or not you want to be a future dean or whether you don't want to do any leadership, you just want to learn how to gel and partner effectively. So I think that's something that we as a discipline, it's not less hierarchical, but how do we reflect on the ways in which we work together so that it's inclusive, that even when and if there's hierarchy, and that needs to happen because somebody has to be the final decision maker. How do we do it in a way so that people feel heard? Because I think when folks are excluded, whether it's rural or any type of identity or any types of positionality, the chances for the outcome to be positive decline. And I think that that's really why equity inclusion is so pivotal across whatever thing you're trying to accomplish. Is without it, you're kind of just trying to top down tell people what's the right approach. And there's a lot of data that shows that doesn't work very well. So
Yeah, no, I really appreciate that perspective. And as you were speaking, I was noticing that like pretty much everything you were saying and how to like approach rural communities is like really goes into our like social work code of ethics that we like learn about and like live by like as a profession, as students, and like all of our classes it's emphasized and like that not imposing yourself on others and meeting people where they are, and that consistency of care and support. So I think that a lot of what you said it really reflects on that, and I appreciate the application in particular to rural communities. So thank you for that.
yeah, thanks, Calvin. And it's rare to meet another rural, a rural of origin person. And I applaud you for getting to where you are because it's not common. There's educational barriers, there's economic challenges people face, and really it's just, I mean, even for me, I think growing up, like just the idea of higher education was not emphasized, I don't suspect, in the same way that I might emphasize it to my own kids or network now, right? It just wasn't talked about. And so I think to get to where you are, you're more of an anomaly to be, having a master's degree, what you said, 19 days, you're close. And so that's cool. And it is rare. And I think, to wear that with like a badge of honor in a sense of like, I'm from this area and it informs my position. And I think, folks often don't think about their place in that way. They think about their other forms of identity. And I think it's just one of many forms of intersectionality that are important.
Absolutely. Right. Thank you so much, Lister. And has been an honor and a privilege to do these research research spotlight interviews with faculty members. This is my last one, as I mentioned that I am graduating in 19 days. And I have learned so much and appreciated the important perspectives that all of the faculty members that I have spoken to have brought. Um, and there are more to come in the future, more of these research spotlight interviews to come. So be on the lookout for that. So thank you so much for watching and have a great
Thanks again, Kelvin, and thanks everyone for watching. Bye.